Welcome, everyone. Today, we're putting on our detective hats. Our case? A very suspicious spot on a brain scan. Now, I know this can feel like a really complex, maybe even an intimidating mystery, but we are going to crack it together. By the time we're done here, you'll have a step-by-step guide to follow the clues, line up the suspects, and solve the case. So let's dive in. You know, seeing a mass on an MRI for the first time, it can feel like you're lost in the woods without a map. There are so many possibilities, but every good detective has a strategy, a system, and that's exactly what we're going to build. A way to take hundreds of possibilities and funnel them down to just a handful of prime suspects.
And here it is. We're calling it the diagnostic funnel. It's our whole game plan. We start broad and get more specific with each step. First, we find our biggest clue. Is it inside or outside the brain? Then we open up the case file. Age, number, location. After that, it's time for the suspect lineup, where we compare the usual suspects. Then we look for the smoking gun, those dead giveaway imaging clues. And finally, we bring in the high-tech tools for the final verdict. See? It makes the whole thing totally manageable.
Okay, first things first, the absolute number one question you have to ask is this. Is this thing growing inside the brain tissue itself? We call that intra-axial. Or is it growing outside the brain tissue, pushing its way in? That's what we call extra-axial. This is the first and honestly, the most important fork in the road for our investigation. So what exactly does extra-axial mean? Well, think of the brain tissue, the parenchyma, as the main party. An extra-axial mass is basically a party crasher. It's not part of the brain itself. It's coming from the outside, growing from things like the meninges, which are those protective layers covering the brain, and it's just shoving its way in. So, how do we spot one of these party crashers? Well, we look for 5 classic signs. The most reliable one is what's called a CSF cleft. That's a little pocket of spinal fluid that gets trapped between the mass and the brain. We also look for blood vessels that have been pushed aside, a little sliver of gray matter stuck between the mass and the white matter, a wide base where it's attached to the dura, or even a reaction in the skull bone right next to it. Finding any of these is a huge clue. Okay, so once we've figured out if we're inside or outside the brain, it's time to open the case file. The patient's age, the number of masses we see, and their exact location, these 3 bits of information are going to shrink our list of suspects down like you wouldn't believe. It's just basic detective work, but man, is it effective. Now, before we go any further into the case file, we've got to understand a key concept you'll see on pretty much every MRI report. It's called enhancement. Why is it that some tumors seem to light up after we give contrast dye while others don't? The answer tells us a whole lot about our suspect's MO. It really all comes down to something called the blood-brain barrier, or the BBB. Think of it like the brain's own personal VIP security force. So tumors light up for one of 2 reasons. Either they were outside the BBB to begin with, like a lot of those extra-axial masses, or they're just so aggressive that they melted a hole right through security, letting the contrast leak in. But, and this is a big but, there are 2 famous exceptions you have to know: pilocytic astrocytomas and gangliogliomas. They're low grade, but they enhance anyway. Total curveballs. All right, let's grab our next clue from the case file. Are we looking at a lone wolf situation here, or are there multiple suspects on the scene? The number of lesions we find is another game-changing piece of the puzzle. Now, if you see multiple spots in an adult's brain, your number one suspect, hands down, is metastases, cancer that's spread from somewhere else. But here's the crazy twist. Get this. About half of all metastases show up as a single solitary spot. This means a single mass in an adult is actually more likely to be a MET than a primary brain tumor. The other reasons you might see multiple masses are seeding, which is when a brain tumor spreads through the spinal fluid, or a genetic syndrome that causes tumors to pop up. All right, detective, we've gathered our initial clues. Now it is time for the suspect lineup. We're going to use what we know about location and the patient's age to put the most common tumors in a head-to-head face-off and see who matches the evidence. This is where the patterns really start to jump out at you. So let's start with a classic pediatric matchup. Down in the posterior fossa, the back of the brain, you've got medulloblastoma, which loves to grow from the roof of the fourth ventricle. Its rival, the epidymoma, grows from the floor. And ependymomas are famously plastic, meaning they literally squeeze out of the ventricle openings like toothpaste from a tube. Once you see it, you'll never forget it. You know, sometimes the biggest clue is also the simplest one. If you see an image that looks like a cyst with a nodule, basically a fluid-filled balloon with a solid little ball inside that lights up with contrast, it really just boils down to one question. How old is the patient? If it's a kid, your prime suspect is a juvenile pilocytic astrocytoma, or JPA. If it's an adult, you're almost certainly looking at a hemangioblastoma. Simple as that. Next up in our lineup, we have two suspects that can look kinda similar but are totally different on the inside. The dermoid cyst is essentially a sac of fat. And since fat is bright on T1 images, so is the dermoid. The epidermoid cyst, on the other hand, is a sac of trapped water and skin cells. That trapped water can't move around freely, and that causes something called restricted diffusion, which makes it light up like a light bulb on a special sequence. So one is bright because of fat, the other because of trapped water.
Okay, what if our suspect is hiding out inside the ventricles, those fluid-filled spaces deep in the brain? Well, two common culprits here are the central neurocytoma, which you'll see in young adults and has this classic bubbly Swiss cheese look to it, and the colloid cyst, which is this perfectly round little lesion right in the front of the third ventricle that can cause some serious problems. And now for the three big aggressive adult gliomas. First up, the classic villain, glioblastoma, or GBM. It's a nasty, irregular, ring-enhancing mass that loves to spread across the midline. Next, primary CNS lymphoma. This one is usually a solid, intensely enhancing mass that really restricts diffusion. And finally, we've got the oligodendroglioma. Look for this one in the cortex, often with calcifications, and it has this weird tendency to look like it's expanding the brain's cortex.
So sometimes in an investigation, a single piece of evidence comes along that just cracks the whole case wide open. In neuroimaging, we call these the smoking guns. These are the buzzwords and the telltale signs that are so classic, they practically scream the diagnosis at you.
This right here is a perfect example. It's almost like a reflex. If you see an enhancing brain tumor in an adult, and it's also incredibly bright on diffusion imaging, meaning it's restricting, the first name that should leap into your mind is lymphoma. It's just such a powerful association, it gets you 90% of the way there.
All right, you ready for a rapid-fire round of smoking guns? Let's go. Zuckerguss, that's German for sugar icing, describes how medulloblastoma coats the brain surface. We already talked about the plastic or toothpaste tumor for ependymoma. Swiss cheese, central neurocytoma. The ice cream cone sign, that's a vestibular schwannoma peeking out of the auditory canal. These aren't just funny names, they're powerful shortcuts to the right answer.
We are so close to closing this case. Sometimes the final piece of the puzzle isn't one tumor, but a whole pattern of them that points to a bigger genetic syndrome. And other times, when the evidence just isn't quite enough, we have to call in the forensics team and use some advanced tools to get the final verdict. For example, let's talk about neurofibromatosis. In NF1, you're on the lookout for things like optic nerve gliomas. But for NF2, there's a fantastic little mnemonic you just have to remember: MSME. It stands for multiple schwannomas, multiple meningiomas, and ependymomas. If you see that combination of tumors, you can be pretty confident you've just diagnosed NF2.
And that brings us to our final and maybe our toughest challenge. Imagine this. A patient had a brain tumor. They got treatment like radiation, and now, on a follow-up scan, there's a new spot that's lighting up. So the question is the tumor back, or is that just scar tissue from the treatment, something we call radiation necrosis? On a normal MRI, they can look exactly the same. It's a huge problem.
So how do we solve it? We bring in our high-tech tool, magnetic resonance spectroscopy, or MRS. It basically does a chemical analysis of the tissue without ever having to touch it. If it sees high levels of a chemical called choline, which is a marker for new cells being made, that means something is growing. The tumor's back. But if it sees high levels of lipids and lactate, which are markers of cell death, that's just a scar. The mantra is super easy to remember. More choline, more problems. And there you have it. We cracked the case. By using a systematic, detective-style approach, gathering clues, checking the case file, looking for that smoking gun, we can take a really confusing, suspicious spot on a scan and turn it into a specific diagnosis. It just goes to show you, even the most complicated medical mysteries can be solved if you just know how to look for the clues. Makes you wonder, what other secrets are hiding in there, just waiting for a good detective to find them?